we both talked about this, about using it as a new clinical trial endpoint. But I just kind of want to stress the point, I guess, because patients are living longer now with myeloma. Running a clinical trial for you, it might take 10, 12 years to read out the results. And you're really looking for ways where you can find results in 3 years or 5 years. And that's why it's being pushed so much as a new clinical trial endpoint, right?
Exactly. As Dr. Fonseca said, the goal is to read out trials as quickly as we can so we could go to the next trial. That is deciding that regimen A is better than B or drug B is better than A. In these days, with such good drugs, such good therapies, it could take years to know which is the better drug. But if we knew for sure that those who achieved MRD 0 in a higher percentage were always going to be the winners, we could result these trials earlier and start to use them in patients and move on to the next study.
Mm-hmm.
Jenny, let me use an analogy for that. You know, it's traditionally we have thought of trials like running a marathon, right? So the gold medal goes to the person that crosses the finish line first. But now we have learned that if you actually look at the 10-mile marker, those that are, say, 30 minutes ahead are always going to be winning, right? So now what we're trying to do is we're trying to convince the regulators, yeah, we can still run the marathon. It's going to take that many years. But we know very clearly, if you're among the front pack by the 10-mile, you're going to win. So, and that's the tension in that conversation. Now, this is very nuanced. I'm just simplifying it just to exemplify why we think this might be a useful marker, because there's examples where there's someone that comes behind at that 10-mile marker and might win the marathon. But we know pretty consistently that is the case. But there's such importance to the consequences of an approval process from a regulatory perspective that's why they're looking at this data in this way. But we're all hoping that we don't have to have 42 kilometers, so 26 miles covered in the future, so we can run marathons perhaps in 10 miles.
Yeah, that's a great analogy. And you referred to the different types of MRD testing because they are different, the flow versus the NGS. I think we need a little bit more description about the different kinds. And then some of them require you to have a baseline and some don't. So can you address that issue as well? And I will jump to questions. I'm kind of butting in here with my
question. We should have addressed it. Ralph, you want to take that one?
Sure. So, and that's going to ask one of the first questions we have here in the panel, right? So there are two methods that are really the predominant ones right now. One is through the next generation sequencing through the clonoSEQ assay, and the other one is through flow cytometry. So flow cytometry is a very sophisticated method. It doesn't require a baseline sample, and you can get the results pretty much immediately if they have that technique available. Now, it requires multiple colors, and people are going to hear about multicolor flow cytometry. And the more colors you have, the more precise you are as to whether you can detect these myeloma cells. While there are some academic groups that can push the limit of detection to 10 to the -6, in general, most flow cytometry that is done across the United States, even in sophisticated academic medical centers, runs around 10 to the -4 to 10 to the -5. So that is, they have the precision to say if there's a cell among 10,000 or 100,000 cells. Now, that does not require a baseline sample. So for like the question number one we have here, if someone, for whatever reason, we cannot get a baseline sample for sequencing, you could think about running flow cytometry. Now, sequencing, the way it works, we take a baseline sample and that sample is analyzed. There's kind of open questions through genetic testing that look for the DNA fingerprint, if you may, of the myeloma cell. So once you have that DNA fingerprint, you know what you're after. So in a second sample, the first one is called the ID sample. The second one is called tracking. So in the tracking sample, you can run the assay again, then you can see if you find that DNA fingerprinting. And that actually is important because you can have two answers to that question. First of all, is whether you detect it or not. So that's an important answer. But one of the other questions that we have down here as well, too, by one of the attendees, they said, is it binary or is it on a scale? And what that question goes to is, should we just say it's positive or negative? The answer is no, we can quantify. So if you standardize the process, we use that to quantify the number of copies. So you can say, oh, there's 300 copies, and then with subsequent has gone down to 50. As you saw from the slides of Dr. Wolf, you can have some fluctuation in the numbers. but we want to get close to that 0. The downside, again, is you need an original sample. So sometimes in a small percent of patients, it's hard to do that, and we just cannot provide the answer.
Mhm.
That, in fact, was the first question here that I see. I'm one of 5% of cases with degraded DNA on the original specimen. I can't do MRD testing. You cannot do MRD testing with the clonoSEQ, next-gen sequencing testing, but it can be done, as Dr. Fonseca said, with flow, Euroflow. I know the Mayo Clinic does this. We sometimes send our specimens there. It's not as sensitive, though. It can't go down to 1 in a million.
Vicky asked a question that's important. When you think about remaining disease, if you say there's no disease left and you can't detect anything by MRD, but there's this philosophy that there are myeloma stem cells that are actually regrowing the myeloma, like, is there any way of measuring that? That was Vicky's question.
Unfortunately, no. We don't know why patients relapse after they get to MRD 0. You know, the most obvious answer is there's some cells hiding somewhere. We know that there may be, for example, a plasmacytoma or a group of myeloma cells in a humerus, an arm bone, that isn't measured when you put a needle in the pelvis. That's an obvious answer, but are there stem cells, myeloma stem cells? Can we see new mutations leading to another relapse of myeloma? We don't know that. We can't measure those stem cells.
And a question from Adrian, who is looking at a variety of different factors. You know, he's watching the M protein levels and the IgA or the light chain levels. So what if you have rapidly increasing light chains, but kind of relatively stable M protein or the other factors? And how does the MRD act in relation to that?
I guess the easy answer to that is that if you can measure the disease in the blood, the MRD has no relevance. It's only when patients are in a complete remission, you can't measure anything in the peripheral blood, that we begin to look at MRD. So I would say the light chains take precedence in this case. Forget what's going on with MRD. The MRD is likely to be quite positive. It would be very unusual for it to be negative.
So George had a question about the idea of cure. Like, you know, it used to be a curse word, I think, in myeloma. When I was diagnosed, nobody was saying this word ever. And now I'm hearing the word. And sometimes patients are being told, okay, you're cured. But in the myeloma world, I think we're really cautious about using that word. Do you want to just address that? You know, like, what is it? He's basically asking, what is the algorithm for cure?
Well, at my age, I guess one definition is my patient outlives me, but I guess there are many definitions of cure. Certainly patients who have myeloma, but it's controlled and then pass away from some other illness, I guess they have what we call a functional cure. I had one patient who was in remission and then fell off his horse and died. I guess he was cured. But not to be joking about it, I've been treating myeloma for 48 years now. I have some patients who haven't relapsed after 20, 25 years. I'm still a little reluctant to say they're cured, but they've lived a normal life. They haven't died of their myeloma. I just don't think we're at a point now where we could point to somebody at any point in their disease course and say, you're cured. It's a little bit like a surgeon leaving a big surgery and saying, I got it all. How the hell does she know?
Dr. Fonseca, do you have any?
You know, that's a great point. I always think that part of the controversy start because no one defines at the beginning what they're talking about, right? So if you think about cure in the sense that, you know, there's no further detectable disease and there's patients who never again experience symptoms, the answer is yes. We have patients like that in our practice. And like Dr. Wolf, I have patients who are now 20 years plus who have no evidence of residual disease and are, you know, carrying on with their lives. Now, I would expand on that to say that there are some patients who still have measurable disease and are, for the most part, are acting as if they were cured. I have patients who have small M spikes, and I have patients who, you know, may have a small abnormality in the light chains and carry on with their lives without symptoms and without evidence of progression. And that's an important caveat because I did mention from the get-go, MRD is a good goal. But if you don't get there, it's not necessarily something that becomes ominous, because there are situations like I'm describing where patients, do that. Now, lastly, my third comment there is that, when you start looking at myeloma, you start looking at the outcomes. Most myeloma patients are being diagnosed now in their 70s and 80s. And with the therapies that are so effective, instead of talking about survival times or median survival, I think another way to think about it is, what is the gap between the expected life expectancy and what you're seeing now after a diagnosis of myeloma? And I think for many people, that gap is not that big. Now, I know we all want to live to 120 and be healthy and being very active, but the reality is that, our lives end up concluding, for those of us that become lucky and, in our 80s, and if we can approximate normal life expectancy when one is diagnosed with myeloma, I would say that's pretty close to a cure.
And people don't know what to do when they hear that word. Like if a doctor says to them, we had some emailed in questions and Susan asked the question, if I'm 5 years out and my doctor's telling me I'm functionally cured, then what do I do? Do I continue therapy? Do I not continue therapy? And Dr. Wolf, you showed some great examples of patients who went many years without therapy, and that's expense and side effect. And so we're all trying to decide, when do we do this? When do we not? When do we stop? When do we start? Everyone wants to stop.
It's a great question, because when we started to introduce the concept of maintenance therapy, it was based on two large studies using lenalidomide as maintenance, one in Europe, one in the US. And the US study showed that continuous lenalidomide until disease came back or until toxicity was better than a placebo. And in Europe, they only used len for a few years. I think it was 2. Clearly, there are patients who do not need to take it forever. And I'm in the camp that believes if we can figure out who does not need it, it's better to stop it because of the side effects, because of the cost toxicity. We can use the drug again later. So I'm hopeful that something like MRD or MRD will allow us, not just one measurement, but several measurements of MRD negativity will allow us to stop therapy, as we have in chronic myelogenous leukemia. I think there's a time when we have to stop therapy. And interestingly, I asked one of Dr. Fonseca's colleagues at one point years ago how long they gave lenalidomide for, and they said until relapse. And then I discovered that the average time patients at the Mayo were on maintenance was only 2 or 3 years, because it's hard to tolerate it forever. It's as much as we say, take it until you relapse, very few patients can.
And Jenny, if I could add to that, I mean, people get all fired up about how we're using this potentially to discontinue therapy, but I mean, the reality is it's not like MRD comes in and is a final decider and pontificates, you're going to continue in therapy or not. It's simply one more piece of information, makes a clinical practice more informed, right? So we sometimes stop therapy for simpler reasons. Someone is more fatigued, perhaps someone has more diarrhea. Yeah. So the way I think about it, the argument is we bring MRD just like we bring the rest of the testing, just like we bring clinical symptoms, patient preference. It's a combination of factors. Mm-hmm. And I always tell patients, I think there's value in measuring it, because if you're in a complete response and you're doing well and you have sustained MRD negative, those zeros that Dr. Wolf shows, but it turns out the burden of the disease is high on you because of the treatment now, because the toxicity of Revlimid, I think it's pretty reasonable to stop therapy. You might have an extra level of comfort knowing that you have the MRD negative. If on the other hand, you're tolerating well and we still are MRD positive and we're concerned about perhaps a more aggressive version of myeloma, that may be extra oomph for you to say, well, I'm going to stay on therapy for a little bit longer. So people shouldn't take MRD as saying, I'm the final decider of where therapy continues or not, but it's simply just one more important piece of information.
Beautifully said, Raf. It is one more piece of information, and there are patients, we haven't mentioned this yet, where I measure MRD in people who otherwise look like they're in CR, and I see the MRD going up. We now know that those patients are going to relapse. So why would we continue the same maintenance therapy if their MRD is going up, if we really want to control it? That's a point to perhaps change therapy so that they don't fully relapse.
Okay, here's a question that I had a discussion with a patient yesterday, and he has had 24 MRD tests.
Mm.
A lot, right?
Yeah.
And he has kind of mathematically looked at it in terms of his length of relapse.
Engineer.
Yeah, when he started relapsing. And he saw just a lot of correlation with the relapse and the MRD was really, like what you're saying, is a really early indicator. So when you get the MRD starting to go up, is that a time to change therapy? Do you do it earlier versus waiting 3 months for your other numbers to go up?
I do. I'd like to hear Dr. Fonseca's opinion, but I do because I find it hard to continue. I find it hard to argue to continue the same therapy when I know the patient's relapsing. Now, my colleagues may say to me, well, what difference does it make whether you change therapy at that point or you change it later? The difference is that for months, perhaps you're treating them with an ineffective therapy. If you saw an M spike going up, you saw a light chain go up, you wouldn't continue the same therapy.
Mm-hmm.
You know, I agree. And actually the same applies in the other direction. So a patient post stem cell transplant who's getting the, DARA-R for treatment of myeloma. And then, the patient's in a CR but continues to go down. How long do you push that for? By measuring the MRD, you see a continuous decrement, then you're moving in the right direction. So I think a lot of this will have to be tested further. Sometimes we doctors, and for good reason, we don't like to, think about, doing things necessarily when there's not a phase 3 clinical trial and the like. But I mean, the reality is there's so many variables in medicine, and in the real world, it's just very hard to know exactly. And so there's a little bit of an art still to how we practice medicine and how this has to be individualized for every single patient.
Mm-hmm. And what you were mentioning earlier about it's just one piece of information in a whole. Jack asked a question about how you use imaging in addition to MRD testing. Do you have any thoughts on the correlations there?
Well, Jack knows as much as Rafi and I know. Sometimes I want to go on vacation and have Jack see my patients, but no, Jack.
We actually do imaging all the time. So as part of our routine, we do at day 100, we do a PET scan and we do the clonoSEQ assay and we submitted an abstract to the ASH meeting, which will be virtual, but we're submitting a paper. The combination of those two really identifies individuals who are very unlikely to require therapy over the next 5 years. So I think it's important. And I know every coin has two sides, right? So if you don't achieve that, or if you don't get into the MRD, I think it's really a key question now for the myeloma community and the myeloma research community. What are we supposed to be doing in those situations? Because I think that's the next big question is, what do we do to try to achieve MRD status in those that are not getting there?
So can I ask Ralph a question? So if you have an MRD 0 at day 100 and a negative PET, you do not put them on maintenance?
I do put them on maintenance still. And after a discussion with patients, and it turns out there's a very unfair thing that happens, and this is well described in oncology and in medicine, is that for those who are doing well, do the best. And, so the idea is that shortchanging the thought of something that we know has been proven in a clinical trial to help, I do that. Now, if a person like that were to get more toxicity, I'd be more easily thinking about discontinuation of therapy, but I have not used that as a reason to withhold treatment.
Mm-hmm. And I have a question that's really common from Bernhardt. He says, if a newly diagnosed patient reaches MRD in induction therapy, should a transplant still be done? And to add to that, I've had doctors tell me sometimes patients respond quickly and deeply, but they relapse quickly. And so how do you when you think about induction, it's usually not that long or can be pretty short for some patients and longer for others. So do you look at that at all?
I mean, it's a very difficult question. We haven't done the studies yet, but we are in the process of doing those studies. I individualize it. If I have an older patient who's somewhat infirm and I can get to MRD 0 with induction therapy, there's no reason to do a transplant. More and more, I'm having really young patients who have great responses ask if they really have to do a transplant because they're aware of the second malignancies that come after transplant. And they just believe if they got to 0, they can hang on till we have say, CAR T cell or BiTE therapies that are curative. So it's interesting how more and more patients are asking if they get to MRD 0, just like this patient asked, can they avoid a transplant? I'm starting to think about it too.
Dr. Fonseca, do you have any comments?
You know, that's one of the most difficult questions. And it's interesting because I'm probably going to be more in the favor of transplant, whereas Dr. Wolf is thought more traditionally as a transplanter than I am.
I have been.
But I, you know, on the other hand, one sees that the long-term benefit of all the myeloma treatments, the one that seems to have the most durable responses is that transplant. So I want to see a future without stem cell transplant, but as of now, I think it, at least in my opinion, remains a key step in those that are eligible for transplant. I should emphasize that transplant is not the only treatment. It's just one of many treatments, but it just provides you another option. You know, it's another tool that we have. So I tend to steer my patients to transplant no matter what, but it's a very deep conversation because arguably you could say, well, the return on investment, so to speak, is going to be less in someone who's already MRD negative at 0, because then, you know, they have very low cells. The counter argument to that is, well, if there's any cell out there that you couldn't detect, now it's going to be taken care of by the transplant.
That said, Raf, yesterday I said the same thing you did to a patient. This is the best therapy we've got for myeloma, and I convinced him to do the transplant. But it's a difficult discussion. And as our therapies improve, it'll be even more difficult to convince people they have transplant. But for the moment, you know, there are the patients who are out 20 years, I'll bet he had a transplant, Raf.
For the most part, that's true.
And transplants become almost ubiquitous. Like I think people know how to do transplant. I've had 2. They're not fun, but they're doable, you know. And some of the strategy might be see how long you can get out, because development is happening so fast that what could be done instead of relapsing early and having to pick another therapy. So I don't know. I'm convinced as a myeloma patient that you're going to get your therapy, whether you get it all up front or you spread it out. I don't know. It's, you know, you get it. So we have some practical questions, like Catherine's asking, why isn't everyone using MRD? Is it expensive? And then Kim is asking, is insurance paying for MRD testing? And then how much does it cost?
Let me try it. So there are 2 reasons why everyone is not using it. 3 reasons. One is, I think there are physicians who aren't even familiar with it. I mean, imagine in the community, and I practiced in the community for 25 years before I came back to academics. The community oncologist, hematologist, has to be treating colon cancer and lung cancer and prostate cancer and pancreatic cancer and breast cancer and myeloma and leukemia and lymphoma, and they can't know everything about everything. And so there are some who are not familiar with MRD. There are some who don't know even how to order it. That's number 1. Number 2, it does require a bone marrow, and a lot of physicians in the community aren't comfortable doing bone marrows. A lot of patients don't want another bone marrow. I think that's a reason. And then finally, it does add expense. There's no question about the fact that it costs. I think that most insurances are starting to cover it. I don't know exactly how much, but I think it's north of $1,000 for each test. But my argument is, if you do a couple of MRDs that are negative and it costs a couple $1,000 and you don't pay for Revlimid for the next 5 years, it's been more than made up for. But I think that's the reason people aren't doing MRDs. It's bone marrow and they're not familiar with it. Rob?
Yeah, and I think that's a very important point, because as clinical research comes forward and continues to evolve, and that becomes standard clinical practice, sometimes people think that there's like this very, very hard wall between one and the other, and it's not true, because as we're learning from this clinical trials, we start adopting some of those practices in how we approach the treatment for patients. So I think we have to look more, I always argue, for value and not for cost, because, you know, and this is not the topic for today, but for instance, we have all these regimens, 4 drug combinations, and then transplant, and then we're thinking maybe some post-transplant, some immunotherapy. Before we know it, we're going to be revisiting that conversation about cure with much greater emphasis. And MRD is going to be one of the key drivers of that. And if we get to a successful place, I was going to say if we're lucky, but it's not really luck because it's the work of many, including the great efforts that patients have made in all this journey. And then we start seeing that patients become cured. The return on investment, again, on MRD is going to be phenomenal. And I think that's really has to be the ruler by which we're measuring our progress.
Right, right. Especially the ability to stop therapies will really save a lot of money, and getting at that question of cure. I think MRD is going to have to be part of that discussion.
Robert has a good question. Is there any single therapy that is you're seeing more MRD negativity in than others? That's an interesting question, isn't it?
I would. Well, for one thing, transplant. I don't think in the old days, 5 years ago, transplant was just about the only way to get to MRD negativity. But I was blown away by the fact that patients who had been multiply relapsed and got, for example, a daratumumab combination, like daratumumab Revdex, could get to MRD 0. This was down the road, like second or third line. And we're now seeing it in CAR T therapies and in T-cell engager therapies where we can get to MRD 0. But people still relapse. I have to warn you that MRD 0 does not mean cure necessarily. It's just that there's a better chance for cure, but it's not a guarantee of cure.
I would say for that, it's usually not one drug, but it's just more the approach of the combination.
Yeah.
And it's very important. So you're going to find perhaps some conversation around this in medicine where people might say, well, it's just biology because there's some patients that are bound to do, very well. And the answer is partly, but only very small. A very small part of that is biology, because the better the treatments, the larger the fraction of patients that can get into MRD. So if you go back 30 years, when you use melphalan and prednisone, no one was achieving MRD. When we use VAD and when we use transplant, and now even in the setting of, for instance, in the relapse setting, when someone is experiencing a relapse, you look at the studies that were done, for instance, with the Pollock study, so daratumumab, Revlimid, and dexamethasone, and a fraction of patients become MRD negative, and in fact, they're usually 3 to 4 more times more likely to be MRD negative when they get that versus a control arm. So yes, there might be some factors that make some people more likely to get MRD negativity, but as treatment gets better, that number goes up.
Do you see differences in genetic factors that patients with high-risk genetic features don't get into MRD negativity as often?
That's a very, very good question, and it's a little bit complex. The answer is complex, but here goes my best understanding of that.
Okay.
There doesn't appear to be a big difference, although it's more likely, perhaps, but slightly, for you to do that in the standard risk patients versus the high risk. But it's far more important to become MRD negative if you're high risk than if you're standard risk. And the reason is that the French have shown this, that if you are able to achieve an MRD negative status and have high risk disease, it turns out the outcome may be just as good, if not better, than if you have standard risk and don't achieve MRD negativity status. Now, the reason it gets complex is there's some variants of myeloma. One of the most common ones is this hyperdiploid myeloma, which occurs more in folks in their 70s and 80s, which I always call like the hibernating, the slow myeloma. So it doesn't respond fast, but it doesn't go away completely. And these patients can have great long-term outcomes. I tell my patients, this is like a bad guest at dinner that just stays for long, but doesn't talk, doesn't contribute to the conversation. That's a hyperdiploid myeloma. So in that case, not being MRD negative is not necessarily bad. But again, at large, from the get-go, it's good to try to get into MRD negativity.
I second what Raphael said, that for high-risk patients, it's much more important to get to MRD 0 and stay there with aggressive therapy for a period of time. And then they act like standard risk.
Interesting. That's so encouraging, I think. So,
and it's a reason why MRD becomes important to measure in certain patients, especially.
Well, it's a reason why myeloma patients need to see you as well. Like we always encourage that because
in the winter they can go to Scottsdale.
it's so nuanced to see myeloma specialists. The disease is so nuanced, and there's so many layers to this. So we always advocate having a myeloma specialist on your team, whether you get treated like with your infusions or not. Go get a consult, from a myeloma expert like yourselves. It's just, it's so
So
critical.
our goal, I'm sure it's the same in Phoenix, our goal is to be available for all patients with myeloma in California or beyond, and to share that patient with their local physician. There's no reason why somebody in the myeloma world can't help all patients.
Yeah, and now we have a lot of telehealth consults, so
Sure.
it's possible. So you should do that. Kim asked a question about accuracy and reliability because things aren't standardized. So there's the clonoSEQ test. This is an adaptive test. I know that they have not gotten FDA approval yet for the blood-based test. I don't know if anybody wants to address that in myeloma, but they have for other diseases. How, and if all these numbers are kind of different, and are there facilities that are creating their own MRD test? Are they more or less accurate? I don't know. As a patient, you kind of want to be able to ask intelligent questions of your doctor.
Yeah.
So maybe
you know, I think how you do it matters a lot. So we have had a conversation with our pathology team. Like, for instance, if we're going to measure MRD, the MRD sample has to be 1/2 of the first aspirate we do for a bone marrow. So we can standardize that because, you know, if you do 3 or 4 aspirates, sometimes the third one gets a little bit diluted with blood. So it wouldn't be as useful if we want to quantify. I would say that it can be done, but it's going to be pretty risky because the technical expertise required to do this, I mean, anyone can do a PCR test, but the technical expertise to require and to measure is quite high. I mean, that's why there's a whole system behind all of this. And some people will try to do that, no doubt. I would suggest that for the MRD testing time point, one has to work with the oncologist, who has to work with a pathologist, and perhaps that's one important time point to work with one of the myeloma reference centers, and not to be self-serving, but there's really the need for the standardization to get the right results.
I agree.
Dr.
Wolf, do you have any comments?
To that point, I don't think any institution should set up their own MRD testing. I think the institution, I think for NGS, adaptive really, I think has shown us a great reproducibility. For flow, I don't even trust my own institution. I do send it to Mayo, but what I've discovered in sending it to Rochester is that if my nurse practitioner doesn't send enough material, I get results like 0 malignant cells out of 798 looked at.
Yeah.
Worthless. So you have to send enough material. You have to send good material. Flow's more exacting than next-gen sequencing. You really have to send a lot more cells. It has to be fresh. If you try to send it in the winter to Rochester, it could get there a day late. Flow is difficult.
Mm-hmm. And then at the idea that we talked about before, getting it at baseline, Jack's asking, if you don't get a baseline as a newly diagnosed patient, can you get it at first relapse?
Yes. And you can get it out of a plasmacytoma if you don't.
Oh, interesting.
You can, anything that's formalin fixed, you can use. It's just that you can't use anything that's been decalcified, like a bone marrow biopsy. But
And just to say, I mean, for the patients that are listening to this, if you had a bone marrow, say, with your private doctor in a community hospital, the pathology departments will always have to save some material, sometimes for very long. They sometimes even save the slides, so the slides themselves can be used for that. They can be scraped off, and from that, they can determine the fingerprint.
Right.
Mm-hmm. Okay, Richard has kind of an interesting question. I think he's being treated by Dr. Berenson in California, and who I know is doing some Vcna measurements to try to detect relapse. So how does MRD compare to measuring the levels of Vcna? Interesting question.
I can comment on that. We actually are doing some work and are working with Dr. Berenson as well too, but are doing some independent work with BCMA. I think BCMA is going to be more like the M protein and the free light chain. It could prove to be a very useful marker. I mean, we are very fortunate that we have so many biomarkers in multiple myeloma that we can track things better. Whenever I have had to cover for other colleagues or work in the hospital wards and I see what they do in other tumor types, I just wonder how they can do that because we have so much information in myeloma. And I think BCMA may be one of those. He has some data that early BCMA responses seem to predict very good outcomes. And then for those patients that have very low levels of the proteins, maybe BCMA measurements will help. But I don't think it's going to be a replacement of MRD anytime soon.
So maybe complementary.
I agree.
Okay. And Richard has a good question. How many MRD negative tests basically do you think you need? Well, this kind of goes back to like, you know, practical things like when do you stop treatment or whatnot. But, and you've talked about it already, holistically, you're looking at the big picture. But in general, what would make you feel comfortable in terms of stopping?
It depends on the situation. In somebody with high risk disease, 1-0 doesn't mean anything to me. And somebody who's having a lot of toxicity, who's been on a drug for a while, as maintenance, and they have 1-0, that might be enough to stop. I think you have to look at the entire picture. We're talking in our world of myeloma experts about two measurements, 6 months apart. But you know, that's made up. A lot of things in medicine are, somebody makes it up. Somebody thinks of it, does it, it works, and we live with it. It's not like we experimented with 6 months versus 7 months versus a year. You know, we just kind of do what we think is reasonable, and if it works, we live with it for a long time.
And when do you, we have a lot of questions like from Jackie and others about when do you anticipate like a blood-based? So we talked, you're talking about the adaptive clonoSEQ test. They are working on that. When do you think that will
So there is, adaptive does have a blood-based assay. It's not as sensitive. And what happens is that, that there are a lot of false negatives. So if you get a negative in the blood, that doesn't mean it's negative in the bone marrow. If it's positive in the blood, and this is a qualitative positive negative, if it's positive, you know that you don't have a 0 and you don't have to do a bone marrow. That's the only way I can use it right now. But there are some, as Rafael mentioned earlier, some newer technologies like cell-free DNA, which might be able to be measured in the blood, that may reflect more than just the bone marrow site where you went, that may reflect plasmacytomas in other sites. One of our problems when we do MRD from a single bone marrow aspirate is that that's all it is a single bone marrow aspirate in that site, and there could be myeloma elsewhere, which is again why we argue for more than 1-0. That, you know, more than one site. And we argue for a PET scan to go along with it to make sure there are no active lesions.
And that's the imaging question we talked about before. Dr. Fonseca, do you have any comments?
You know, I have to say the blood versus the bone marrow may be a question that cannot be necessarily solved with technology or a new test, just because the nature of myeloma is to be in the bone marrow. It's a little bit, you can imagine if you're looking for a deer and you know the deer tend to be in the forest and they don't come out into the open grass, no matter how good your glasses are, you still are going to find the deer in the forest, right? So I think you can think of MRD that is positive in the blood as a useful bit of information perhaps, but if it's negative, you don't know if it's still in the bone marrow or not. And I think that's just a reflection of the nature of the disease.
Yeah.
And then Bonnie had a question, when you're trying to get MRD approved as a clinical trial endpoint, are you using a standardized test? I mean, is that the push in terms of research?
Yeah, I think there's since we have the FDA approved test, we're hoping the FDA will move in that direction. And this would be good for everyone. I know, I mean, the tension is there for a good reason between people who do clinical trials extensively and the FDA, the agency. But as we mentioned, I mean, the test is pretty standardized. So we have that information. It's just whether they have the comfort to move forward with that. Now, I think it would be good because it shortens the duration of trials, brings therapies faster to patients, arguably will bring down the cost of drug development. So it should make them more accessible. So I think it could be good all around.
I would think most people, in our world, most physicians treating myeloma can't wait for that day. I mean, it's really, but the FDA has been a little bit slow on it. I've argued that I mean, there are other situations where drugs are approved rapidly and then there are some post-approval studies that are required. I would argue that we could do that with MRD, that as we could say, drug A is better than B at this point using MRD, but we'll reevaluate it. But we have to continue the study and reevaluate it if for some reason B turns out to be better than A.
Well, Sharon has a practical question. How does someone become eligible for MRD, or how do you go about the process of getting an MRD test and when?
Well, it's really up to the physician who, you know, they're oncologists, they're hematologists. If they'd like an MRD, they ask their hematologist. If they're not comfortable, then the discussion has to be had, I suppose, with the center that is doing it. It does become a little more difficult if your physician says, we don't need it, don't do it, it's worthless, it's expensive, it doesn't change anything. Then you have to debate whether you want to get a second opinion.
Mm-hmm.
But it's easy to do and order and send it off.
And she asked too, kind of the difference between complete response and stringent complete response. Does Dr. Fonseca, do you want to define what that is?
Sure. So the stringent complete response was an added descriptor that was added by the myeloma working group to standardize response criteria. And it just reflected that you needed to have no detectable cells in your bone marrow by, you know, advanced staining through pathology, and that the light chains had to be normal. So it was just one step forward. Stringent complete response is great, but now what we're learning is even you have to go beyond that. And if you can be stringent complete response, then that's a situation where you would definitely want to measure MRD. Even just you know, complete response, but stringent complete response is the target population for measurement of MRD. Now, the good news is, and I know this applies in different ways, but with the best available regimens, there's a high fraction of patients that get into a complete response after induction and stem cell transplant. And that's why MRD has become such an important topic.
Mm-hmm. Ari asked kind of an overarching question, and what's the pathway toward making these more granular decisions, like whether to transplant, whether to consolidate, what kind of maintenance, when do you suspend maintenance? Using MRD as a tool, like he's saying, it seems implausible for us to get trial results on adaptive algorithms in more than a few simple cases like the master trial. So what's the pathway?
Yeah, I wish we had something equivalent to, I don't know, like Minecraft, right? So we could virtually run all the clinical trials and have the answers to that. Yeah. It turns out, and this drives particularly, I think Jeff alluded to some of our, you know, our fellow citizens who are engineers and math specialists crazy, because there's no predictability to biology. So it always turns out that biology has surprises for outcomes. So we have to run these clinical trials. But I think Ari's point is excellent in that the trials have to be adaptive. I think the master trial, for those of you who don't know what that is, so they, you know, they look at the achievement in MRD and they decide what follows at different time points. And once a person has 2 MRD negatives, they stop therapy. I think it's commendable. We'll need a lot more of the trials like that. And I think we need multiple pathways. I mean, medicine has come a long way. We came from a time where it was like very old drugs, and by the flip of a coin, you added a third drug, to situations where we have at least 7 major subtypes of myeloma. Note, I said major because we don't even know the secondary mutations and all of that. And then levels of response, and then patient characteristics. So the permutations of how this is played out in clinical trials is almost infinite.
Yeah, it almost seems impossible.
Yeah, it's, I have to echo what Raphael said. It's for my patients who are engineers, and there are an awful lot of them in the Bay Area, medicine makes them crazy. They don't understand why their M spike doesn't fall when they plot it on semi-logarithmic paper, why it doesn't make a straight line.
Mm-hmm. Yeah, I think that's one of the reasons that we created HealthTree, because we wanted to be able to capture all the real world, what's happening really in the real world, and see if there are correlations. A patient had a question about solitary plasmacytomas. So solitary plasmacytoma 10 years ago, removed, no evidence of myeloma. Will they end up having evidence of myeloma? Are MRD tests helpful there?
Well, I'd like to speak to that, because I've been making a case, and I have a number of patients already, and I've been thinking of reaching out to my colleagues for others, where we used to define a solitary plasmacytoma in a very strange way. It was a plasmacytoma, obviously a single plasmacytoma, and the marrow could have up to 10% plasma cells, which never made sense to me that was called solitary. now we're getting to a point where we're saying at least a solitary requires, a certain kind of solitary requires a stringent CR in the marrow. What I've been doing in all of my solitary plasmacytomas is taking, getting DNA sequences from the plasmacytoma and then looking in the marrow to see if there's any MRD. And if there's measurable residual disease, I have found over the last 5 years of doing this that all those patients ultimately develop myeloma. And those who are negative MRD at the time of their solitary plasmacytoma have not. Now, I only have about 10 patients, and I need to have a lot more before I publish this. But Bruno Paiva in Spain showed this many, many years ago using flow, I think, that if you're MRD negative in the marrow at the time of a true solitary plasmacytoma by PET scan, that you probably never will develop myeloma if you've radiated fully the original.
You know, that's such an important conversation. I think a plasmacytoma is one of those instances where I would recommend an immediate consultation with a specialist, because you have to determine whether it's that, which they read in a textbook that was written 20 years ago, versus whether that's the first manifestation of evolving myeloma. And sometimes a plasmacytoma may be the tip of the iceberg, since we're talking about icebergs, and making that determination is critical, because then just crossing your fingers and hoping that things are fine and not preventing someone having a fracture down the line or renal disease is really not good practice.
Yeah. And the difference up front, Ralph, is that I had a patient in Southern California who had a solitary plasmacytoma. They were going to radiate it, but only to 2000 centigrade. If it's a true solitary, it has to be fully radiated to 4000. And that distinction should be made by truly looking hard with PET scanning, with bone marrow, with MRD, I believe.
And there's a question here I'm going to answer. Just plasmacytomas use the term we use in medicine to describe a lump of myeloma cells. So they come together, whether it's small or large enough that you can see it on an X-ray or feel it. That's what a plasmacytoma. And the solitary definition is just when you just find one side of the body where you find a lump like that without evidence of myeloma elsewhere.
Steve asked a question: how frequently do you recommend MRD testing to measure relapse? And we talked about, so every 6 months, every year, if you're MRD negative.
Yeah. So again, this is something that we'll never be able to study. It's sort of what I've taught my kids. It's sort of what feels right. Should we do it every week? You think a patient would allow us to do a bone marrow every week, or would you do it every 4 years? Certainly not. That doesn't give you information. So I work in from both sides, and I kind of think in an individual patient, 6 months seems reasonable to me. And most patients kind of like 6 months to, in between bone marrows. In some situations, like the high risk situation where I've stopped therapy based on multiple MRD negativities and many years of therapy, at first I do every 3 months because I'm really worried about high risk coming back quickly. But we'll never have a study to tell us what's right.
And I'm going to put in a plug-in for something that we do here at Mayo, and I think it should be considered, everywhere. Our bone marrows, we do them with sedation. I always say I have done this in groups like this and gotten an applause, and I know it's more complicated, but I always say, if I was a patient, I want to have it with sedation. We do them with propofol. I mean, even if you're great, it still can be associated with pain, and it just allows us to think about more easily doing that. I know that sometimes creates challenges with my colleagues who don't do them at other institutions, but I feel it's an important way to facilitate this. And it's just like, it's like childbirth, right? If we didn't have the epidurals, it would be a different world. So why not use sedation?
Yeah, no, as someone who's had probably 15 plus bone marrow biopsies, I started kind of getting PTSD after a while, and that's my go-to. So ask your doctor if you can get conscious sedation at the facility. It's an important question. Bonnie asked kind of a follow-up question of what we talked about earlier. For patients who are getting MRD negativity quickly, why do they also relapse quickly in some instances?
There's a reason for that, is that in general, for some of the cancers, this applies to cancers outside of myeloma as well too, the ones that are more proliferative tend to respond more rapidly to treatment. So aggressive lymphomas respond rapidly, and the same is true for leukemias. But if you do have one of those variants, it's important you do the response to completion. And those are the settings where getting an MRD negativity is important. The group from Arkansas had published many years ago that if you had high risk and you had achieved a CR but then quickly relapse, that was not a good sign. That would indicate a very, very aggressive form of myeloma, more challenging to treat. But the reason is believed to be that. And that's the opposite of what I said before with the hyperdiploid, which is kind of the more hibernating, you attack it with drugs, it goes away, but only partially, it stays there in the background.
Right. Yeah, I agree with Ralph. And we've said this several times in different ways. People with high risk disease can get to MRD 0, but it's not enough. You've got to keep treating them and to keep them at MRD 0. The question is how long? That we don't know, but you can't just assume that in a high risk patient with a disease that's reproducing itself quite rapidly that you can just do one MRD 0 and quit. And Rob's, for sure, on the other side of this is a lot of patients after they've gone through therapy are left with smoldering disease for years, like Raphael said. So they'll never have an MRD 0. They do fine.
The one analogy I've heard from this was from my colleague, Dr. Hari in Wisconsin. So I shamefully stole his analogy, but he said, if MRD can cause a lot of anxiety, and sometimes it's like if you're in your house and you hear sounds in the basement, sometimes those sounds are mice, which is suboptimal, but you can live with that. So those would be kind of the more indolent forms of myeloma, but sometimes it could be a tiger. And so there's not optimal. So you have to deal with that. And that's how we think about, the standard risk and the high risk versions of MRD positivity.
And Christina is asking a question. Can you go from MRD negative to MRD positive and then MRD negative again?
Yeah, so I actually showed that slide of my patient who went from 0 to 2 to 0, which, and in my mind, they're the same. And in fact, because not every assay, for example, flow can't get better than 10 to the minus fifth at best, we actually defined MRD negativity as MRD negative at 10 to the minus fifth. So that patient who had 002, 002, 00, she was by definition MRD negative each of those times. Now, sometimes the adaptive report, when you get it back from adaptive, when you order a clonoSEQ, it'll say less than 1 or 0, and then in parentheses 0 to 2, like it could still be 0 to 2. That's just a warning that 0 is not always 0, and you can go 0, 1, 0, 1, 0, 2, 0.
Okay. Some of the questions are, I have X percent of, like 10% of cells in the bone marrow, but you've said this before that you don't need an MRD test if you have, you already have myeloma, right? So that was one of Beverly's questions. And Adrian asked the question, I relapsed after 2 years of MRD negativity, even though I've been on Darapom-Dex as maintenance and exposed to RVD in the front line. So when you're looking at, like you were saying earlier, Dr. Wolf, when you're thinking, I'm going to change therapy because this is no longer working, like at that point, what looks to be an attractive option? And there was another question about CAR T, that a lot of CAR Ts are seeing a lot of MRD negativity immediately after CAR T. But is it just like when you're taking that measurement, or I don't know? So let's talk about treatment options a little.
So the first, it's always hard to make recommendations about treatment options when you don't know the whole story. So I tend not to take questions from patients that are very specific, but if a patient's had a full exposure to the IMiDs, the proteasome inhibitors, a transplant, and daratumumab, some research study would be appropriate at this point, whether it's a CAR T or a antibody drug combination, or a BiTE or T cell engager. I think. I mean, there are other drugs out there, but they're short-term in side effects. I think you've got to think about something more aggressive. And then I guess the second question was?
I think I've exited it now, and so
I think we had answered it before.
Yeah. Okay. Okay, so Christina asks, why not get a clonoSEQ MRD to get a volume of positive cells, even if the light chains have increased, but not to the level of relapse? Like, is there a good correlation between what you're seeing on the MRD and your light chain numbers? I mean, are you taking both of those factors into account?
So think of MRD as the test that you do when the light chains are normal.
Mm.
We've just published that as the MRD goes up, at some point the light chains are going to start to show positivity, and that that sometimes happens more quickly, but our average time is 11 months from first. I mean, if you go from a 0 to a single digit to a double digit, we know that patients are going to relapse, but it can be a year before they start to show it in their light chains.
Mm-hmm. And Dr. Fonseca, do you want to answer this question by Jeff? Do you think mass spectrometry, which is kind of being developed, maybe you want to give a little bit of background, can be used as a less invasive way to measure MRD? Is it related to measuring something totally different?
Sure. Well, it's a little bit different. It's a more sensitive way of measuring the proteins in the bloodstream. For those of you who don't know, so mass spec it speaks to the technology, so it can go down to very, very low concentrations of protein. This is something that is being used first for diagnosis. So, you know, people are doing studies to find out how many people have abnormal proteins. I don't know if this is reassuring or is more worrisome, but it turns out once you start going with mass spec and you start looking at the population at large, actually a larger fraction of people than we suspected have MGUS-like proteins, meaning, you know, more people kind of have this precursor conditions. And this is not unique to myeloma. You know, in lymphoma, there's some tests for lymphoma that show about 1 in 2 adults have a few lymphoma cells in their body. Again, I don't know if that's reassuring or is something that makes us worried, right? But it's just a reality. Now, that same technology is being brought forward to test for MRD in the blood. I know our institution has actively participated in this. It still needs to go through the clinical trials. Like everything else in myeloma, it turns out that I predict it will be complementary. I think it's going to be one of the various tools. I sometimes tell patients, you know, when we decide about what to do next with your myeloma, is like flying a Cessna plane, where you have all those different gauges in the dashboard, and it's a combination of all that information that guides where we should be going.
And Dr. Wolf, do you have any comments about mass spec?
No, I think it'll be complementary. I don't know that it'll replace MRD.
Can you both also clarify a little bit? I think sometimes when you hear about flow and then NGS MRD testing, it can get confusing for patients because when they think about NGS testing, they're thinking about genomic testing and like, you know, getting a foundation medicine test or testing the genomics of it. Can you just clarify that a little bit for patients?
Let me try.
Okay.
With next generation sequencing that is done for MRD measurement, the goal is to identify a DNA sequence that is specific for that patient's cancer plasma cell, and sometimes several sequences are identified, and then to use that sequence as a probe in the future when the bone marrow looks normal to try to find that needle in the haystack. And that's not total DNA sequencing, and that's not looking for mutations. That's simply trying to find an identical sequence of DNA in a new sample. Flow is something totally different. Flow is looking at proteins on the surface of the cell using the antibodies that have different colors, as Raphael mentioned. But the kind of DNA sequencing that is done by, say, Foundation is looking for mutations.
Yep.
Yeah, and you know, one of the ways I would describe it, the MRD by sequence that we measure, it's like the core element of the B cell. So when the B cell, before it became a myeloma cell, was already a B cell that produced antibodies, it has a sequence from which it won't change. And that's why I call it the DNA fingerprinting. So that is a core. And there was another question somewhere there about the subclones. No matter how many subclones you have, every single subclone has the same BDJ sequence. The other mutations, and so it will be from the beginning until the end of the life of that particular cell. The other ones are the ones that we acquire as a consequence of you know, DNA changes in our body, and some of which lead to myeloma. And I describe them often as typos. So the typos that end up changing the story, that's what mutations are.
Okay. I think we'll have a final question by James, who's saying, in the future, will it be possible to go to even more sensitive testing, like 10 to the -7? And maybe somebody, you kind of referred to a little bit on your chart, Dr. Wolf, when you were showing, 10 to the -7, 10 to the -6. But can you just kind of reinforce for patients that they need to pay attention to their numbers when they're getting that test back about what the sensitivity level of the test is?
Right. So that's even more important for myeloma doctors or physicians or scientists looking at the reports of studies. When a study claims that 50% of patients who got this therapy achieved MRD negativity, but they only look at 10 to the -4, that doesn't count. Will the day come? I certainly believe that we will be able to measure better than 10 to the -6 at some point. The question is whether there might be some other way of measuring myeloma that's totally different, that really will tell us if there's a myeloma stem cell there. And that could be a long time coming, but something else is going on when patients who are negative at 10 to the -6 still relapse. It may be more than just one cell hiding in your toe.
Yeah. And
I believe our tests will become more sensitive. Yes.
Yeah, I think so. I mean, it seems like development continues with everything, right?
Yeah. Well, just look at where we've come. I've been, like I said, I've been treating myeloma for over 40 years, and there was a time when any response at all, when we just had melphalan, which was melphalan is phenylalanine mustard. It's a derivative of mustard gas from World War I. When we only had melphalan and a little bit of steroids, prednisone, and if the M spike dropped, well, we didn't have M spikes back then, but if the IgG dropped from 4,000 to 3,900, we were ecstatic. As our drugs got better, our need to measure got more important, and we're now at a point where so many patients achieve stringent CR, and that's more than 50%. It's 70, 80% if you're aggressive enough, that you need some other way of measuring it, and that's what MRD is.
Yeah, absolutely. Dr. Fonseca, do you have any final comments about MRD and progress?
No, thank you for the opportunity. I just want to say, because I know that there's probably many people here who are listening who have not achieved MRD or are worried about their MRD status. Please know that the conversation is more than anything a description of the progress that we're making in myeloma. We never had this conversation when we didn't have the tools to achieve that. There's many caveats, but hopefully we have a future where the majority of patients can get into MRD negativity.
Well, go ahead, Dr. Wolf.
No, I agree. I think I think patients have to see this as a continuum. We've come a long way. We still have a long way to go. MRD is going to be another important factor in how we measure responses and how we make decisions, and then it'll be surpassed by something else. That's how it's been for 40 years. That's how it'll keep going. Yeah,
well, to me, the development that's being done in multiple myeloma is truly stunning. If I had to have a cancer, it would be one where there's a lot of development work being done. There's so many different therapies and so much coming up, and we have amazing specialists like you working on it. I'm really hopeful and very encouraged by all that's happening. We have other questions. We're going to try to answer those offline because we're running low on time. I want to thank Dr. Wolf and Dr. Fonseca for joining us today. It's just stunning that you're willing to join us and answer all these questions. It is so helpful for patients. We share it online afterwards so people can go back and refer to it. We have a link. The link you used to register can be watched later as well, live on demand. And I just want to thank you both for coming out of other meetings too this morning and coming in on a Saturday to help patients. So just thanks to you both.
Well, I'd like to thank you, Jenny, and the people who work with you to do this. It's, education is so important in every aspect of our lives, but especially when you're dealing with cancer. the more the patient knows, the better partner they are for us to be able to treat them. They understand what we're trying to do, and you do become partners.
Mm-hmm.
Jenny, let me second that as well too. And perhaps one thing I'm going to offer is that if there's anyone in the crowd that it's more sort of scientifically oriented to go into more detail, I'm going to send you a link. We can post that maybe in Facebook with an conversation I had with Dr. Lanny Kirsch, who is really the scientific director at Adaptive, and we talked about some of the nuances. It's a longer conversation, but if you want to hear more about the details of the sequencing, you can go to that.
Oh, I would love to do that. And we will include that link. But with that, I just want to thank you both. I'm going to stay on for just a few minutes and show patients also where they can access MRD resources inside of HealthTree. So you're welcome to stay on, but I don't want to keep you if you have another meeting to jump to.
I'm sure that Rafael has 3 more Zooms.
No, thank you. Bye-bye.
Okay, bye-bye. And I am going to share my screen. And HealthTree, as many of you know, is a way for you to navigate your disease, but also contribute to research. So what I want to show you is just a few ways you can access MRD-specific resources. Under Track Your Myeloma, you're tracking different things like your diagnosis and your team, your current health and fitness status, treatments and outcomes, and your labs. We have added MRD. We didn't start out with it, but we have added it now as a lab value that you can add. There are ways you can add your labs. Because MRD testing comes in as a separate report, it's not typically something that you import, basically. It's like a report that goes to your doctor's office, and sometimes you have to request it and show, say, can I have my MRD results? So right here you can see I have my myeloma markers, and at the bottom, my MRD number is at the bottom. You can add new labs, and if it's, well, for other labs, there's a variety of ways, as you can see, about how to enter your labs. But for MRD specifically, you need to add them manually. So you'll enter a date of your test. And then you would enter the value right here. So you would select the test type, flow cytometry or next generation sequencing test. You would put the number of cells found, and then you would put per 100,000, per million. So this is 10 to the minus 6, this is 10 to the minus 5, and this is 10 to the minus 4, which is the number of zeros, basically, that's in there. So that's how you record your MRD results. We also have many classes about MRD testing in HealthTree University. And it's in class, so if you do a search on a topic in HealthTree University, you'll be able to see which classes are for MRD testing. So we've invited over 75 myeloma experts to be our faculty in HealthTree University. And it's just been a fantastic effort. So thanks to our program director, Cindy Shimlowski, for putting that together. It's really unbelievable what's been done. But there are a lot of questions about MRD testing, like what is MRD and why is it useful? How is it used as a prognostic tool? How is it done? How accurate are the results? These classes will be updated on a constant basis. So what we do this year will be constantly updated as the technology of MRD testing evolve. And that's what I wanted to show you today. So with that, I would like to thank all of our participants. We really appreciate you joining us on a Saturday and becoming your own best advocate. And thank you so much for joining us today.